Okay, good morning, everybody. I think we are ready to start, and I am very happy to welcome you all to our symposium on affirming neurodiversity in autism care that we are organizing at the occasion of the successful PhD defense of Gert-Jan Vanaken yesterday evening. You all received a little booklet in which you probably found the program for this morning. There is a rough timetable there. We will try to stick to the times, but we won't be very precise, but we will make sure not to make it longer than scheduled in the booklet. In case you need some practical stuff, in case you need toilets or in case you need a quiet space, that is available, and I will explain now. So you leave that door, you go to the left, take another left, and then go to the first floor. So stairs up, first floor, and there you will find toilets and a quiet space. So feel free to make use of that. We are here with a rather small group, well, not a very small group, but a rather small group, but there are many people online, so I think we are about 200 people online. So also welcome to the people who are on the live stream. In case you experience any technical questions, I will try to follow up, so don't hesitate to send me an email. My email address is right there on the screen, and I think you can also find it in the booklet. In case you have questions for speakers, so we will have 4 presentations this morning. There will always be a presentation and some time for Q&A. In order to give people that are following online also the chance to ask questions, we decided to use the slido.com application. So maybe that is something you can already open either on your telephone or on your computer. So that will be where we ask you to put your questions. One of the people involved in the organization of the day will take care of the questions and will make a selection. Of course, we won't be able to answer all the questions, but we will definitely keep all the questions, and we see this day as the start of something for the future. So we will definitely hold on of all the questions and make sure that we take care of them at some point. Maybe to start, we will give the Slido a little bit of a tryout, and I think Gert-Jan will help me with that. There we go. So here's the link to slido.com. You can also scan it if that's easier. And the login is on the screen, but also right there. And it's also in your booklet, so you can find it in many places in case you need it somewhere this morning. Okay. Many people saying hi or congratulations to Gert-Jan. That's very nice. We have 3 questions for you as to try out the Slido and so that you get used to the Slido. Question number 1 is, which city are you joining from? So for people struggling, there should be polls in the Slido. So there is one place for questions, there is one place for polls. Join, Chris, no problem. Yeah. So we are scrolling through. We see many places in Belgium, in the Netherlands. Lots of people either in Leuven, Antwerp. Okay, that gives us a bit of an idea. Thank you. We will go to poll number 2. And there the question is, from which role or roles are you joining this symposium? You can select more than one option, obviously. That gives us a little bit of an idea of who we have right here, but also online. And as you can see, can you scroll up a little bit, Gert-Jan? We see many clinical practitioners, researchers, autistic persons, parents to an autistic child, and others. It's changing a little bit, but not so much. And I see that already above 60 people have casted their vote. Leave it there. Okay. And then the last question. What brings you here? And what do you hope to hear and learn? Maybe just in one word. That's difficult, isn't it? 2, 3 words, okay, but not long, long letters. Insight and inspiration. That sounds like what we are aiming for today, isn't it, Gert-Jan? Okay, thank you. Time to get started, I guess. And well, I'm very happy then to introduce the first speaker who is standing right next to me. And that is Gert-Jan Vanaken. Gert-Jan is trained as a medical doctor with a focus on child and adolescent psychiatry. And over the last 5 years, he worked on a joint PhD, a PhD in educational sciences at KU Leuven and a PhD in philosophy at the University of Antwerp. As I already said, he defended successfully yesterday evening, and he worked on the ethics of early autism detection and intervention. Over the coming years, and as a postdoctoral researcher, he will contribute to the IPANIMA project, which is a project in which we hope to develop neurodiversity affirmative autism psychoeducation. And you will definitely hear more of that maybe today and definitely in the future. Today's presentation is titled The Earlier the Better, Parents' Views on Early Autism Detection in the Era of Neurodiversity. Gert-Jan will discuss findings from his recently finished doctoral research, and he will specifically zoom in on an interview study he conducted with parents of a child at increased likelihood for autism on the benefits and risk of early autism diagnosis. Gert-Jan will discuss the findings and their implications for early autism care in the light of the ongoing paradigm shift towards neurodiversity approaches to autism. Gert-Jan, the floor is yours.
Hi, good morning, everyone. So for people who were here yesterday already, it's hi again, and to other people joining, really glad to see you here. And thanks for the nice introduction, Ilse. As Ilse said, I'm happy to present a piece of my research, more specifically an interview study that me and my colleagues conducted. So you can see the names of people who were involved in this study next to me. And since there are, especially online, many people joining that I haven't met before, I always like to introduce myself a bit more. And I'm not such a big fan of titles, but just for today, I put there my PhD title just for one day. I think I'll just take credit for that. But what's maybe most important to say is that I'll speak from a non-autistic identity, which is which I find relevant to say, but at the same time, also think that identity is not the only thing that matters. And as you will hear throughout my presentation, what I will try to do and what I've tried to do in my research is explicitly do my research and also today to speak from a neurodiversity perspective. So that's not my identity, but it is my standpoint. Voilà. What I will do today is discuss some findings of a specific study, but also try to generalize those findings a bit more broadly to think about how to provide good and just early autism care. And there are two things that are context-wise, I guess, important to know about this interview study that I conducted. And the first thing is that this interview study, it was actually part of the ethical work package of a larger study, the TIARA protocol, which is a prospective and a multi-year follow-up study that some colleagues of mine in Ghent and in Leuven have been working on. And you see my office partner, Melinda, doing some of the testing here. And you also see Isaac, who is the son of one of my colleagues, who was one of the participants. And my colleague explicitly asked me to say that her son looks a lot more handsome these days than he looked at this picture. I think he does just fine. So that's one part of the story. And next, context-wise, another part of the story is that we found it important to conduct a study on the ethics of early detection as, and this is also the reason that we're here today, there is this paradigmatic change ongoing in the autism field, or at least I try to proclaim that it's ongoing, and I think also by continuing to speak about it, it's also happening, or at least we're trying to contribute to that. And what's important in this paradigmatic change is that we try to see autism no longer just as a set of deficits to be prevented or as a risk to be contained, but also as an expression of diversity to be accepted and accommodated, and also to give proper attention to. Into the microphone? Ah, yeah, this sounds better. Yeah, okay. And also in this paradigm change, what's really important is to give proper attention to lived experiences of people on the autism spectrum, but also when we discuss this very young age group, I think it's also important to take on board the perspective of parents. Voilà. And it is against the backdrop of this paradigm change that we're trying to reflect on the question what it means to provide good and just autism care. And so concretely, what we've done is, or the research questions for this interview study were as follows. We wanted to know from these parents taking part in this multi-year early detection protocol, what they see as advantages and disadvantages of such such early detection, but also how they experience, these parents, how they experience their role as parents of a child who has been labeled at so-called risk of autism, or at an increased likelihood for autism, because it seems like these parents, especially in the Flemish context, those are the parents who have most hands-on experience what it means to be part of a program that tries to identify autism characteristics at a really early age. And so what we did is we conducted an interview study with 26 parents. It was mostly duo interviews, so parent couples. And I went at those parents' places at home, and I spent about an hour and a half with them to talk about these questions. And at the point of interviewing their participating children in the TIARA study, they were between 11 and 16 months of age. And then afterwards, of course, we transcribed and analyzed those results. I won't zoom in too much on the methodological issues because of time reasons. But I'd like to discuss some of the findings that we that came out of this interview study, and I think some of the findings are some of those findings are maybe quite what we expected. But I tried to highlight some of the findings that are maybe a bit newer or more interesting for the debate on ethics of early autism detection. So when I asked parents what, in their perspective, were advantages and disadvantages of obtaining such an early diagnosis, we had parents speaking from a certain experience they had themselves because they already had an older child with autism in their family, and other parents who didn't, so they mostly talked from certain anticipation. So that's important to keep in mind, that it's a bit of a difference between participants. But there are three main themes that came across, and the first one is that obtaining an autism diagnosis helps to gain a different perspective, both on their role as parents, but also on their child. So that's more of a cognitive thing, I'd say. Secondly, an early diagnosis is something that helps facilitating to do things differently. So on a behavioral level, to parent differently, to take different choices. And as a third main theme, We also noticed that such an early diagnosis, or a diagnosis in general, it doesn't only bring benefits, but it's also associated with many ambiguities. And the role of parents in the way that society is organized these days is often to be some kind of a navigator and to try to balance the advantages and disadvantages of an autism diagnosis. And what I will try to do now is to highlight two of the sub-themes that came out of our analysis. And the first one is that, as I said, a diagnosis, it often helps parents to start doing things differently. And what struck me is that for many parents, they told us, like, we already anticipated that our child would be autistic, and we already knew a bit what things could be that we could do differently in our parenting, but just obtaining the very label, the very official diagnosis, it really provided a click, and it made us also justify to do things differently, and also as parents to justify for ourselves that we as parents also diverge from what we conceive as normal or typical parenting. And I thought that was also an interesting finding. So they discussed a diagnosis as some kind of a turning point. And I'll just give some example quotes, because this way it comes across maybe a bit more clearly. So there was one father who said, it's a father from a family where there was already an older child with autism, so he really spoke from a certain experience as in parenting an autistic child. He said, once you get the diagnosis, it clicks, and things suddenly fall in place. It makes you deal much better with the story, which is definitely a psychological thing, because nothing actually changes. But because someone else defines what is going on, I was like, okay, yes. And then it became much easier to determine how I reacted to him, so to his son, in our interactions. Another parent couple said the following. So the father said, before we relied much on the standard educational practices. So we put him in the corner, we gave him timeouts, we already followed a triple P, so a positive parenting training, which did not work at all for him. And the mother said then, yes, so you stick to the parenting patterns that you've been raised with yourself, and also that triple P training and so. And for years we've been putting him in a corner until that corner looked all brown from his dirty hands, until they told us that was pedagogically useless for children with autism. So if you can detect autism earlier, that would be a lot easier. So I guess that exemplifies a bit how also the diagnosis opens up space for parents to start thinking and doing things differently. What I also noticed is that, especially for fathers in this group, and especially fathers who had less experience with autism in general, this official diagnosis was maybe even more important to make this shift in parenting behaviors, as really several of them said that the diagnosis was needed for them to justify to make all those kind of exceptions, and they felt that there was more of a risk of starting to spoil their child if they adapted their parenting behaviors, while in their opinion that maybe wouldn't be that necessary. On the other hand, and this comes from the group of parents where there's already an older child with autism, there were some parents who said, okay, also for a younger child, we really think that it's important to obtain such an early diagnosis as soon as possible, because it took a long time for all these kids to get this diagnosis, and now we really want to know, we want to be sure so we can do the right thing as parents. But then there was also a smaller group. Sorry for the noise. A smaller group of parents, and I found that also quite interesting. They said, okay, we have an older kid with autism, and we started to do some things differently in our household. And by doing things differently, and by creating some kind of a new normal with the way that we interact with our children, there's a bit of less pressure for our youngest child to really start a diagnostic assessment, because of the way that we organize our family already accommodates some of the needs of our younger child. And one mother said the following about that: "If our daughter would have been the firstborn, we would already have done the test, probably. But now our boundaries have shifted because of our older son. Also, some adaptations we made for him simply became common practice in our family. So maybe the autism-related difficulties will be less noticeable for her." So for me, this was an example that the kind of the need that parents feel in relation to obtaining an early diagnosis, also to a certain extent context dependent. It's also clear that an autism diagnosis, it serves a certain function. For some parents, it serves a function to really justify to parent differently. But if parents already made a certain shift to more accommodating parenting behaviors, this urgent need to obtain the diagnosis to justify their different parenting becomes a bit less urgent. Then a second theme that I want to highlight is comes from this third theme on navigating ambiguities. And what parents also shared with me is that when they used this diagnostic label in public and to third parties, it came both as a blessing and a curse. And in many occasions, I think this is nothing new for people who are a bit familiar with this. The diagnostic label, it can feel really helpful for parents. It can help them understand their child better. It also gives a recognition also for the difficulties that they experience as parents. But also the diagnostic label can be mobilized to, for example, in daycare or in schools or in leisure activities, to justify or to ask for the accommodations that are needed. So clearly, the diagnostic label serves some beneficial functions. At the same time, what came up regularly is that even when parents felt the need to share this diagnosis to obtain some of these benefits, they often mentioned that, for example, in schools or in other settings where children pass their time, that there's often a lack of adequate autism knowledge, and also that if there's certain knowledge available, that it often comes down to quite stereotypical or negative or more all-encompassing views of autism. So you feel that parents acknowledge that it's important to share this diagnosis in certain occasions, but at the same time, it's a bit of a double-edged sword. And one father said the following about this: "This sharing of the diagnosis, it's also a risk towards others. And very quickly you get a stamp like, okay, this child has autism and everything which goes wrong will have to do with that. They will already look different at our child, and I would find it regrettable when a teacher immediately sees the document that mentions the autism diagnosis and therefore changes his practices without truly knowing the child." You can really feel the ambiguities, because on the one hand, of course, the parents want the teacher to accommodate the needs of the child, but at the same time, he also wants that it doesn't become some kind of one-size-fits-all solution. Another father said the biggest advantage of obtaining an autism diagnosis is, the biggest disadvantage is the pigeonholing. And as parents, we could start looking for solutions within that certain category, within that certain pigeonhole. But outsiders, they never think broadly within these categories. And people always think they know what it's like to be autistic, while in fact, it's such a broad spectrum. And another couple said his diagnosis, and then she referred to an older sibling. The diagnosis is known at school, but during parent-teacher moments and during care coordination meetings, they often start talking about his weaknesses and difficulties. And only at the end, some positive points are highlighted. And then the father said, and this is not always necessary. As parents, it's also really nice just to hear that your child is simply doing well, rather than that the parents tell us, we do not notice so much that autism affects him that badly. So this is, I guess, another example that parents really experience. I think it's our coffee arriving for the break, so it's also gives some noise, but it also has some advantages coming up later. Thanks for closing the door. Voilà, so parents are quite aware that there's often a need to share the diagnostic label, but as I said, it's a bit of a double-edged sword. But some parents, especially parents who are in this trajectory for a longer time, also noticed that some parents try to actively resist this kind of prejudice among third parties. And one way to do this is to try to engage in a more open or a more value-neutral discourse themselves about autism within their family, but also when addressing third parties. And so one father said, if you're overly protective of your child, then everyone will look at your son like, oh, he has autism and this and that. And some people in our environment will definitely panic. And then it's our job to say, okay, act normally. These are the things that you need to take into account. And so I think the father said, stigmatization is something you have control over yourself as a parent. So this was a parent who isn't a parent to an autistic child yet, so he's more anticipating to how he would react. And you can see that was kind of a down-to-earth kind of guy, and he felt like, okay, we can also address prejudice among third parties by just engaging in an open and a bit more neutral kind of discourse about autism. And then another mother said, autism, it's simply present in our family conversations. It's a very normal thing. It's very ordinary. So let's not be silly about it. No taboos. And maybe that's the biggest advantage of having an early diagnosis. So for her, it was important that already from an early age, they could start talking about autism in their families in a fairly open way. And she contrasted this position with other families that she knew where an autism diagnosis only came, for example, in adolescence. And then this news, it can drop more, or it can disrupt family life a lot more. And in her perspective, when an autism diagnosis came earlier, it would be easier to engage in such an open and more value-neutral kind of conversation from early life. Okay, I think I have about 2 minutes left, so I'll try to highlight some conclusions. I think overall I could say that these 24 parents that I interviewed, that there was that they held an overall or a largely positive position, or they valued timely autism diagnosis largely positively. But what it's important to know, I guess, is that it's they did so because they actually occupy quite a difficult societal position, and they also did so because they took efforts themselves to make this diagnosis valuable. So I think what they actually brought across is that the potential benefits of an early autism diagnosis, we cannot take them for granted, but they also are reliant on how parents actually deal with this diagnosis. For example, we've seen that parents try to do efforts themselves to normalize or to destigmatize the autism diagnosis by engaging in certain conversations with their peers. And in this sense, one of the things that we suggested in this study is that an autism diagnosis is not simply descriptive. It doesn't just describe what children are like, and it's also neither just functions in a prescriptive way, in the sense that a diagnosis not only brings about certain advice about how parents should behave, but a diagnosis also opens up a certain kind of space, and that's what I would call it can also be productive, in the sense that it offers a way for parents to start thinking differently about their child, about their role as a parent, and also to renegotiate what autism as a label, what it actually means, and try to resist some of the dominant discourses around autism. And this aspect of an autism diagnosis as something productive, I think that's something that in clinical practice, maybe we can try to facilitate even a bit more. Because up to now, I think often when we engage, for example, in psychoeducation, we often do more of this descriptive work, trying to explain what autism is. And maybe also in guidance, we do more of this prescriptive work, trying to advise parents on how to behave, but actually engaging in a critical reflection with parents and trying to see how over time they can also be more of an active player in trying to rethink what autism means and how they can contribute to to renegotiating the meaning of autism, I think that's something we can do more in practice. And there, I think more neurodiversity kind of approaches to autism can be really helpful. And I just put in a paper here that makes a similar claim that it's important for diagnosticians to try to engage in or with a neurodiversity perspective from the early start. And this is also something that I advocated for in my thesis, but I think I'll skip this for now. And maybe just the last thing I wanted to say is that also this idea of trying to think more critically with parents on the meaning of an autism diagnosis, that's something that my colleagues and I will be working on in the next few years when we try to develop a new way of doing psychoeducation with parents in a group-based setting where we also involve autistic experts by experience and trying to really do this more productive work and engage with parents also as critical thinkers, as advocates for their child, and as societal change makers. So that's work that will come up later, and I think that's it for now. Okay, thanks.
Okay, Gert-Jan, thank you for your presentation. There were some comments on the app, but also some questions. We won't have the time to answer all the questions, but we'll start with some more practical questions and then some more conceptual questions. First question, and I'm combining a few questions together. Some people were asking whether you can tell a little bit more about the group you have been doing this study with. Were there neurodivergent parents included, something about the age of the children, and maybe also about socioeconomic status?
Yeah, I went a bit quickly there. So we interviewed 24 parents. They were all white middle-class parents, so that's not very diverse in this perspective. None of the parents actively identified as autistic themselves, but also I have to say that I did this research or started this research a few years ago, and I think if I would do it again, I would pay more attention to this aspect and maybe also try to find ways to ask how parents identified themselves in a better way, because now I mainly based this when I say none of the parents identified as autistic, that's based on the conversations that we had, and none of the parents actually brought it up. But I think if I would redo it now, I would also really include this in my background questionnaires, and that's something that I didn't do. So children were between 11 and 16 months of age. And was there anything else? No. Yeah. No. Yeah, so it were parents already included in this Tiara study, and it's something that we know in research that, especially in longitudinal research, when parents really have to take an effort and to come multiple times to the university, that we mostly attract middle and upper class parents. And then especially if you ask within this group of parents who wants to do an additional interview study, you will get a selection of the selection. So that's really a disadvantage. At the same time, there's not that many parents in Flanders who have a certain experience with early detection on autism, so that kind of justified to go for this group anyways. We tried to include also parents who were invited to take part in this Tiara study, but who declined. But that was really difficult, and we actually didn't find anyone who still wanted to do the interview afterwards, which I can understand.
Then maybe a very broad question, Gert-Jan. How do you think about the relationship between a neurodiversity approach versus a transdiagnostic approach to early autism care?
Okay, that's maybe challenging. I think what we can have in common maybe is that I think it would be valuable that in early childcare in general, it would be beneficial to kind of come to an acknowledgement of diversity in development, and that we, as clinicians, for example, in the well baby visits, but also in child daycare centers and in in nurseries, for example, that there is this awareness about diversity in development, and that we have an attitude of always expecting heterogeneity, always expecting differences in development, without necessarily having to label these differences immediately with a categorical diagnostic label. And I'm certainly not against categorical diagnostic labels, but I think that's maybe where neurodiversity approaches and transdiagnostic approaches have something in common, that it's, I think, beneficial to always expect heterogeneity, and also in the way that we organize care for young children, to take this always into account, that children are just developing in different ways, and that one way is not necessarily superior to the other. I'm trying to look to people for some confirmations, but maybe it doesn't. Yeah, it's something that maybe we can think more about. It's, just thinking out loud here.
Some of the other questions I see on the app, I think would require quite some time to answer, so I don't think that's really feasible. Maybe I just look around if there's someone here in the room who would be interested in asking one final question. And if not, oh, yes.
Hi, I'm researcher from University of Antwerp. I was wondering if when you talk about the new normal of this parenting styles, whether these parenting styles can be accommodating for non-autistic children too, whether this has been researched, and if not, would you think it would be useful?
Maybe repeat that answer.
So if I understood well, the question from the audience was this new normal kind of parenting styles, whether it has been researched, whether accommodating to an autistic child's needs, whether it also works well for the non-autistic siblings in the family. And I think that's like a really a good question, and it's maybe too easy to say that what works for autistic children works for any child, and I think any parent would say that it's not the case. Well, of course, there will be things in organizing a family's life that would be beneficial for all children. But I think it's also good to acknowledge that there will always be conflict, and some of those aspects are, for example, I think around sensory sensitivities, where some children just really need a lot of input and really like to give a lot of input, and for other children that can be really overwhelming. And I think it's also just a reality that, and there's probably a lot of other examples to give, that these kind of things can just clash. But just by heart, I don't have any research that I can refer to, but I think it would definitely be useful to look into that.
Okay, thank you, Gert-Jan, for your presentation, the answers to the questions, and I think we will now move on to the second speaker, and the second speaker will be introduced by Christine Hens, who is also one of Gert-Jan's supervisors.
Hello, everyone. I'm very happy to introduce Professor Hanna Bertilsdotter Rosqvist today. She's a neurodivergent associate professor in sociology and a senior lecturer in social work at Södertörn University. And her current research interest is about developing new tools for neurodivergent research, methods and ethics, both autism and ADHD. She's been involved with autism research since 2008 with a lot of publications. And since 2022, she's also involved in developing research, developing neurodiversity approach to ADHD. So welcome, Hanna. Looking forward to your talk. So, what? So, yeah.
Okay, I hope this will be working. And this is really a first draft. I just started to think about this for some while ago because I felt that I'm I'm educating social worker, and I'm a senior lecturer in social work, but I'm also a sociologist. And I sometimes find that in social work education and in social work practice, we have a lot of tools, which is totally fine to use in the contact with neurodivergent people, but we don't use them. So I'd like to kind of start to kind of merge community social work, which I think is quite acquainted to use as different kind of tools to work with minorities of different kinds, mostly ethnic minorities, but also sexual and gender minorities. So there are the tools already. But when it comes to neurodivergent people, suddenly they are just looking around them and see what are we going to do with this, and look for tools from psychology, from psychiatry, from somewhere else. But I think the important thing is think that we do have the tools, but I like to combine the tools we do have with perspectives from neurodiversity studies. And this is not final, it's just somewhere I'm at right now. So I'm ask you to bear with me my kind of a bit of messiness. So as I was introduced, I'm a neurodivergent researcher, and I'm trying to make this as a kind of a call for more. So I really want to kind of invite both social work practitioners who might be in age of neurodivergent themselves and neurodivergent researchers in social work to come to me and start to make things happen in this field. So some background, and I won't read all those things, it's just to kind of see that there are some problems we do have with a lot of problems really in mental health care and simply low quality of life. And it's not something which we just encounter in our younger ages, it's something for life. So even if it's really important with this kind of early diagnosing and early detections and support in the families with young children, I just want to stay here as an adult and to kind of set this clear that this is an adult problem as well. We don't only have childhoods, we also are adults. And the problem here also in Sweden is that a lot of those kinds of supports and what is there is mainly directed to families and to children. And what a lot of research has been kind of stressed is there's a lot of barriers to health and social care, not only for families, but also for adults. And at the same time, and this is some kind of other backgrounds, this was one background. And then I'm thinking about different kinds of meeting ups I have had as a neurodivergent researcher, talking about my research with other people. And for some while ago, I met up with the clinicians who we kind of exchanged experiences because I kind of got an arm accident with my bicycle for some while. So I had a kind of newly experience of emergency departments. And he sets like a kind of hypothetical question. What to do when there's a big and strong young autistic man at risk of being violent to both himself and us, the environment. And we have a lot of other emergencies to attend to. What do we usually do? We give him sedatives in order to decrease the risk of violence. And for me, it's like, oh, if I get a meltdown in this kind of context, will I become sedated? Is that a risk I will counter to when I'm kind of getting into emergencies? I'm kind of in a stressful situation and my kind of arm isn't working, it's really hurtful. Fortunately, I did not get a meltdown. I was kind of in control. But still, this kind of narratives is quite stressful to hear, and you're kind of thinking back of your own experiences of emergencies departments and what could happen if I get into my non-communicate mode, because it's one thing to speak as a neurodivergent academic with a lot of experience of research and be able to speak about yourself and everything else, and then in certain situations you get non-verbal and you can't speak and somebody says, oh, you got a meltdown, we can't handle you, we have to sedate you. And I like, I really I can't have a meltdown in these kinds of contexts. So I just said to him, what about the roots of all these? His stressors or my stressors, the sensory communication needs, the barriers. And this was really my kind of personal feeling of what would it be like to get into that kind of mood that young man probably was in, if I was in his body. And the sense of, it's not only about being in this terrible situation and this kind of sensory communicating barriers and the stressful situation with the arm is really hurting and you're not really sure when you're going to get care because you're just waiting. And also to be at risk of being re-traumatized, as it's not only about the situation, the actual emergency, but also to think about this place. I don't really want to go there anymore because I might be seductive. So it was kind of a bit emotional to talk with him, and he did understand, of course, I agree with you, but there's simply no time, space, and extra staff. Where I'm going to put him, where I'm going to put me. Also, what is going to happen if an autistic person gets into emergency department and there's no time, space, and extra staff to manage me? So this is just one background. This is just me thinking about how to found a middle way between my sensory and communicating accessibility needs and barriers at these places, and also understand the limitations due to restricted financial resources affecting all in the emergency departments. I really do understand that clinicians did really want to help, but he didn't know what to do. So a third background, as I'm an educator in social work, I'm thinking about these kinds of traumas and also the newly graduated social workers, which I can encounter. I'm meeting up with them when they are writing their thesis about different kinds of things. And I hear the stories from my community, what is happening or what may happen when they are meeting up with those newly graduated social workers. There are a lot of kind of narratives in the community about social workers meeting up, families in crisis, mainly mothers in crisis, and may not have the experiences of working with neurodivergent people before or quite new to the field and get panicked. They are just seeing this as a crisis, I have to act, and they may place the child in foster care due to the sense of neurodivergent mothers' parental deficits. And this is a common story in my communities. I'm thinking about mothers in my neurodivergent communities afraid of being unfitting mothers, afraid that the social worker will choose to place their children in foster care if they turn to a social work for help in the parenting, because they are usually needing help. But it's really a barrier when you're really afraid of the support persons and then you're not knowing what the support person is going to do. So it's not only about sensory barriers like these doors, or that you're not sure if people are going to be able to understand what you say, but you not know if they're going to support you and understand your kind of crisis, or if you're going to take your child away from you. So the fourth background is I'm living in neurodivergent communities and different kinds of communities. And among them, there's a community on Facebook for neurodivergent researchers. So we are a community of ourselves, supporting each other in different ways during our kind of research careers. And there's quite a big group, 5,253 people currently all over the world. And it's English-speaking people, or we speak regardless whether our mother tongue is English or not. But then there's also my kind of mothering group, as the Facebook group number 2, which I'm part of, which is for autistic women and non-binary autistic people, and it's in Swedish. And it's 3,627 members. And I just want to say something about this Facebook group number 2, because I think here we have the expert by experience, community of experts by experience who are kind of doing social work. And that is one of my problems here, is that we have, at least in Sweden, we have a kind of welfare state and a kind of ordinary, okay, professional social work doing their things. But there's a kind of barrier or a cliff between informal social work done by the communities and the professional social workers. And it's kind of sometimes, and most times I think, the professionals doesn't know that the community is doing social work. And if you talk about expert by expertise, they're really doing the expert work. It's not like, oh, are we really aware of, do we really think they're doing some good work? Yes, they're doing work. They're doing, first They're doing community psychoeducation. So when someone is about to get access and has got the assessment and are a bit confused about it because there are a lot of confusion, they ask directly into those Facebook groups, what is this meaning? Why? What is the differences? What does it stand? And sometimes there's a copy-paste from the assessment post in the Facebook group. And a lot of people is just directly describing what it means and what is happening here. Well, how can you interpret it? So it's a completely kind of indirect communication, community psychoeducation. Also, those people who are newly diagnosed, someone is describing something and ask whether this is autism. Do you recognize this in yourselves? And a lot of people say, yes, I recognize this is myself. And when I feel like this, like when I get the first impressions of a meltdown, I do like this. So this is the feelings and this is how I do it. It's a very practical psychoeducation, very practical social work. So the problem with social work, again, is like we have two different kinds of social work. We have the professional, the formal social work, the paid social work, and we have the community social work in the more non-formal, informal community way of doing community social work. So, for instance, examples of community social work in this group is like someone asks how to engage with health and social care professionals, including whether particular healthcare settings, like in Stockholm or somewhere close to where the person is living, is knowledge about autism in women, because we know that there's a little bit of imbalances when it comes to knowledge. There's a knowledge gap when it comes to people. Some professionals do have quite old age ideas of autism in women, and they are looking in the wrong direction mostly. And people are afraid of going to those kinds of healthcare settings in order to be able to kind of maybe be confronted with these kinds of, oh, but you are social, oh, you can look in your face. You are, yeah, but I'm a woman. I'm not a 4-year-old boy. I'm sorry. And I have never been a 4-year-old boy. And you're looking for a 4-year-old boy when you're trying to assess me whether I have autism or not. And this doesn't work. So the community is really very much about, can I be relying on this kind of professional? Should I go somewhere else? Because if somebody have really bad experiences from one of the service professionals, the community will say, well, don't go there. So I think that's important for the professional communities to understand that it's not like, oh, I'm meeting up with one single person. I'm meeting up with a person who have a bagage of community behind a person. The community is saying whether this could be trusted or not, and how to kind of also to act in the world. So for instance, someone in this Facebook group may ask in the morning, hey, I'm at the Stockholm Central Station now and a problem. What shall I do? And a lot of people is just reacting, giving advices. What to do? Yes, do like this. Oh, great. Thank you. Thank you very much. So it's a lot about community education, community psychoeducation, community social work, community sociality, friendships. We have a memo Tuesday. Not every Tuesday, but a lot of Tuesdays we have these kinds of memos posting, and founding and finding friendships. And of course, everything is activist, but I think one of the kind of parts of the very concrete parts of this activism is a book project which I'm currently leading on autistic sexuality, genders, and relations. And there was also a kind of a reaction, because there was a Swedish book for a while ago which about autistic sexualities, written by 2 psychologists who was talking about how to support autistic people in their dating and sexuality. And we found out, but what is this? Are you joking with us? Also, we are kind of adult people. I understand that some people would appreciate this, but don't talk as you know anything about autistic sexualities from your neurotypical psychological perspective when you kind of been meeting up with some autistic people. That is not okay. So this is kind of counterproduct against that book in some way. Can anyone take care of the time? I don't have a clue. 5 minutes. Okay. So I won't get anywhere, but I just want to say something about the 5th background, and that is community social work with minorities, which I think is important to look at. So it's not only to think that, oh, there isn't anything. It's just that kind of unknowledgeable social work. It is a lot of things. Just you have to look elsewhere. You can't look at social work with autistic or ADHD clients or families with. you have to look at other kind of settings. And I found a lot when I'm looking at community social work with ethnic minorities and LGBTQ communities. And something important there is a value that social work is supposed to be an ally to their communities. And it's not a new tradition, that is community social work. It is to be an ally and to be responding to diverse community needs based on strong alignment of values and effectively addresses changing community needs, because we always change, in order to strengthen civic and community engagement. So that is the central in this is the idea of service provider culture competence and affirmative therapeutic practices. And I will kind of switch now because I've been thinking a lot. Oh, sorry. But I've been kind of thinking a little bit about what does it mean? Because sometimes you think about enhancing cultural competence and speaking different languages is about understanding that there are different kinds of neurotype languages. When I speak with a neurotypical person, I mostly try to translate between my autistic mother tongue into a kind of understandable for neurotypical's tongue. Sometimes it would be kind of barriers in communication, but it's not like we do speak, I'm speaking the wrong way and you are speaking the right way, but it's more like, which Damien Milton has been theorized as a double empathy problem. There's a kind of difficulties in translating between different kinds of neurotypes. And if you as a professional are not aware of this, it will be problematic. So that is one thing, is to kind of enhancing cultural competence, is to be aware of speaking different kinds of languages. So when you're encountering an autistic person or an ADHD, you will kind of encounter another kind of language, and the professional responsibility to this is not to demand that you are supposed to be speaking in your languages, but you are kind of have to learn to broaden your cultural competence, to broaden your possibilities to speak between different kinds of neurotypes. To what I'm kind of been thinking about as a kind of, it's part of questioning a neurocognitive privilege and to learn to speak in a kind of more cross-neurotype way. And another autistic researcher has talked about this as cross-neurotype communication, but it's similar to Damien Milton's double empathy problem. Damien Milton is kind of presenting the problem of double empathy problems. And Hillary and me and other people are trying to think how to make this translation better the neuroculture competence. But then it's also back again to the inspiration from community social work with minorities, as mostly ethnic minorities. It's not only about engaging with or increasing your neuroculture competence. It's also, of course, back to power, to be aware of that your kind of power is not really a thing which you can just get over if you learn to speak in a more cross-neurotype way. But you have to, as a neurotypical professional, you have to question your neurocognitive privilege, similar to you as a white professional is trying to kind of question your racial privilege. And what does that do when you're encountering ethnic minorities? But also to be aware that this is not only about individuals, it's about structures and how to challenge structural violence. Working with, for instance, back to my, I wouldn't say it was a trauma, but it was kind of a bad experience to be in the emergency department, and how to work with a minority who has been living with different kinds of traumas, because we are living in a structural violent world. So it's also to back again to back to basic. So it's working with different kinds of support with people who is traumatized from different experiences. And of course, back to the neurodiversity paradigm, to work with strength-based approaches, which is also common when you're working with ethnic minorities or LGBT communities, to increase resilience among neurodivergent people as neurological minorities communities. So I think that is a combination. If you think about neurodiversity, and you think about the families and the children, you have to think, and now I think you need to think more about communities. And communities is not families. Communities is like my Facebook group, the autistic people. There are different kinds of communities. Of course, we shouldn't leave the families. I don't say that. But you, as a professional, you have to be aware that the autism community is another thing than the autistic community. And I want to kind of suggest that we need to work more with neurodivergent or also autistic communities in our professional work. So. What shall I do now?
Thank you, Hanna. Yes, there are many questions online who really corroborate your experiences, etc., etc. Maybe we'll start with people in the room. Anyone has a question? Yeah, Laura? Yeah. So Laura asks, yeah. Someone in the chat asked to repeat the question, which is a very good question. So Laura asks whether, as a clinical that she understands as a clinical psychiatrist, that it's very important for neurodivergent people to find their own community, but that it's very hard, at least in Belgium, for a clinical psychologist to find these communities, to sort of help people engage with these communities. Hanna, do you have anything, suggestions or tips, or anyone else in the room for this?
I think first is that I think a lot of people will find their communities online anyway, but I think it's important for a professional to understand that they are part of communities. So you don't have to perhaps find the communities for them, but they are part of communities. But when you work perhaps with an autistic client, maybe do it in a group. Because I think that is kind of empowering. When I kind of meet up with other autistic people, something is happening. And it's not only when I kind of meet up with one single professional, when I have a therapy session with a therapist, it's not that empowering. But when when I'm working or I'm socializing with a group of autistic people, something has happened with me. So I think that is group work one, and then probably they will be part of communities. And you can kind of perhaps ask them, what would you think, to pose a question to the communities, ask them, and to kind of work with the communities.
There's, yeah?
Maybe for you to repeat, Christine, there are a few big Flemish communities, so maybe we can link to those.
Yes, yeah, Ilse says there are a few big communities in Belgium, so maybe we can link you up with them later. There's a related question online. Do you know of any guidelines being developed for health practitioners to accommodate and provide autism-informed care that is less traumatizing to us? Or is this something we could think about?
I'm sure there are people who know this, but I don't have it in my head.
Yeah. So, yeah, I don't neither. I think it's work in progress, no? Yeah? Or a few, yeah? Yeah, so... Okay, the ASPIRE guidelines, I will put it in the chat as well. So,
and I think quite recently the paper of Mary Doherty and colleagues is also on how to provide space in mental health care, and that's also, I think, a good one to start with.
Okay, let's put it in the chat later on. Other questions? Yeah, Jeroen, or?
Is it okay? I wondered whether you have any advice on how to bridge the gap between the informal and the formal care. It's a very broad question, but
I think the easiest one is to look for the professionals with autism or ADHD. I think they are the bridges. Similar to the research environment, we are the bridges between, because I'm part of the community and I'm a researcher. You have to look for, and sometimes they come out and sometimes they're not, but they are there.
Thanks.
Someone online says, yes, thank you for mentioning our different languages. So a lot of people who share the experiences, but they also ask, isn't verbal, non-verbal a false binary? I'm very verbal, but find myself unable to speak out when in distress. Could my experience be valuable in this context?
That is also perhaps a communication problem. Because I'm a Swedish person, I'm not sure what words we could use, because I just have that in my head. But for me, non-verbal, verbal, it's more a matter of whether I'm better as now I'm kind of speaking, but when I'm in my less speaking mode, I'm not non-verbal. I'm totally fine when I'm kind of writing. So it's really complicated with those terms again.
Yeah, I totally agree. Maybe, and also verbal is very much focused on words as a means of communication, and there are many other ways people communicate that are not verbal. But if we constantly keep calling that non-verbal, we sort of forget that they're also equally communicative and equally valuable, I think. Yeah. Yeah?
Someone online asked, and I wonder the same thing, is how can I learn to speak in a neurodivergent friendly way?
Back again to the community work with ethnic minorities. What do you do? I am not sure, but sometimes you need to learn the language, which means you have to be with people. But I'm sure that people starting to engage with ethnic minorities have to learn the language, whatever that kind of common language is. But you have to learn to, if you sign or whatever you do, but you'll have to learn to communicate. But you just have to stay here. You have to be aware that you can't stay here. You can't just, oh, this is my language, I will communicate in this way. No, you have to broaden your way of communicating.
Thank you. I'm learning a lot from listening to these presentations. I was wondering about if you don't mind commenting on your role as a bridge among different communities. And so one thing in your presentation is the presentation of Facebook material, or I don't know if it was actual Facebook material, but your participation in groups and then representing them in settings like this. I just wonder what, for those of us who aren't in those groups, how we would recognize good practice when we ask people to serve as bridges or go to people who serve as bridges between communities.
Oh, this is a bit hard to answer, because I think it's a matter of better practice. As I find it hard to kind of define what is good practice. But I can understand when I'm looking at the communities, they're talking about better practice, because if you encounter a service where you have to kind of get your partner with you, because there's a stories also that they don't go to the healthcare alone, because they know that the clinicians will misinterpret them. So they will get their partner with them, their neurotypical partner or a friend or whatever, to be the translator. And there we have a bad practice. And it's not like, do it like this instead. It's like, this is a bad practice. You have to make it better, because we have these interpretation problems. And clinician can't keep on misinterpreting the expressions in my face and say I'm not depressed, because you don't see depression in the way you are supposed to.
Thank you.
Yes, I think we should have a break now. Thank you, Hanna. This was really inspiring. I also learned a lot. And let's have a coffee or water or whatever you need now. I think it's in the next place, corridor. Yeah.
Okay. Good after break, everyone. Also for the people online, we're starting again. It's a great pleasure for me to introduce Professor Jonathan Green to you. Jonathan is a child and adolescent psychiatrist at the University of Manchester in the UK. And throughout his career, he has combined a clinical job with an impressive research career. His clinical and research work focus on autism, at least in the last 2 or 3 decades, I understand, Jonathan. And more recently, in particular, on autism in very young children. Jonathan is not only focused on diagnosis, but also what comes after an early diagnosis. I think he has, at least in his research and clinical research, fulfilled the criterion of actionability that Gert-Jan has developed in one of his papers. And Jonathan is involved in the development and testing of developmentally oriented programs for young autistic children. So what can you do after a diagnosis of autism has been made in a very young child? Today, Jonathan will present his current model for parent-mediated developmentally focused program and its effect, after which there will be some time for reflection. Jonathan, the floor is yours.
Thank you. Thank you, Jean. It's a pleasure to be here. My aim is to bring some aspects of clinical practice and clinical science, clinical research into the conversation in the room and online, into conversation with neurodiversity ethics. So it's an interesting conversation, I hope, that we can have together. I woke up this morning thinking about this 10-year-old boy who was the first autistic child that I ever met. I was a very young clinician, actually younger than Gert-Jan, and I was so young and it was so long ago that I had no words to frame the experience of meeting this child in the school who I was asked to see, and who I had, it felt like to me at that point, no frame of reference to engage and make contact with in a useful way, in the way that I have felt I had been able to do with other children. That was a big challenge for me, and it's remained so through 30 years of clinical work, of working therapeutically, clinically with autistic young people to try and understand their experience and often difficulties. So this boy, he did this picture for me of a visit to Buckingham Palace in London. Those of you who've been there, this is his picture of the visit to Buckingham Palace with the windows and the gates. I think it's a beautiful picture that I've always treasured. But he's really here to say this is my experience, where I come from clinical practice. And I want to talk with you now about how we might engage in care for very young children from early childhood, very early childhood, with a view to making a difference to this boy's experience later on. Whether we'll be able to do that, that's for you to judge, and I'm not sure, is the truth, but I want to share with you some of our experiences and the results of the trials that we've done. So the basis of this takes us into the intimacy of early infant-parent relationships, the first interpersonal experience that we have in all of our lives. These interactions between babies and young children and parents that have always been the focus for developmental science researchers and clinicians. And we know a lot about how this happens in neurotypical development, let's say, but also in some different kinds of development. And the key thing from this is these dyadic transactions between the parent and the child. So what's come out of a lot of this research is that the key focus for what makes a difference is what you could call attunement, or what some people have called goodness of fit between the dyad. And there's a quality of the interaction, not of either party, but the quality of the interaction that is the predictor for later outcomes for the child. And this is foundational for our understanding of early child development. And if we get these attunements reasonably good early on, good enough, this helps the child's resilience later on in terms of social communication and various aspects of their development as people. This is like established work. The question for us here today and for us in our work as clinical scientists is, what happens to that when the baby, the infant, the young child is neurodivergent? Can we approach these interaction experiences in a way that's helpful and meaningful? And can we apply the same frame of reference? The fact is that all children, whether neurodiverse or not, live with parents. We were hearing about that in the last two talks. So this is practically relevant. The question is whether it's, as it were, clinically relevant. Well, we've done a lot of work looking at these transactions with neurodivergent young children. I haven't got time to go into that work, but we do understand a bit about how those transactions go. And one of the ideas is that if those transactions don't go so well, if there's not that attunement, then there are potential vulnerabilities downstream for neurotypical children, but also arguably for neurodiverse children as well. And so, in a way, what we're talking about here, in my view, the way I frame it, is really the earliest form of environmental adaptation. There's a lot in the neurodivergent conversation community about adapting environments within a neurotypical world to the neurodiverse autistic individual. This, to me, is the earliest manifestation of that. This is the earliest environment we have as people. And so the aim of what we really do in the work that I'm going to describe is to try and attune this early environment best to neurodivergent early experience. But I acknowledge here, right off as a discussion point, that there are some assumptions made in this work, right? So, and I'm going to come back to these as I talk a little more. The assumptions, particularly that are these normative, as it were, neurotypical processes relevant to the neurodivergent experience? And that's been the subject of quite a lot of debate and comment. So I acknowledge those assumptions, but I'm going to come back to them later, and I want the science to speak for itself to you. So what we do in our interventions is we work with the parent side of the dyad. So we don't work with the child at all. And the reason for that is because the parents are, we think, most likely to be able to change and adapt. They're adults, they're formed human beings. And they are the people who are with their children 24/7. So if we can help parents adjust and adapt, that's going to have an immediate 24/7 knock-on to their child and the family. And therefore, potentially, it's extremely efficient, if you want to look at it like that, as a therapeutic thing. So the intervention works with the parents. And this is not psychoeducation. I don't dismiss that. That's a perfectly valid form of thing to do. This is a therapy, because the level at which parents need to make the adjustment is beneath cognitive. So you can learn, and it's important to have a cognitive frame and understanding and knowledge, etc. But the kind of adjustments we're talking about here are real-time adjustments every day and every moment, which are beneath the cognitive. And we use video feedback as a very effective way, as it's proved, of doing this. I just want to give you an example of what the video feedback looks like. So we take a video of the mother with the child, or the father, any caregiver, it's fine. And then we look at that video with the parent collaboratively. I mean, the thing I want to get across there is this is a collaborative process. It's not teaching. It's like mutual exploration. And the whole point is the parent in a reflective space, watching the video, watching herself and the kid, is able to reflect on and find things out. And it's that light bulb moment of finding things out, guided by the therapist, that lodges in the mind. So we've done a lot of research on this kind of method, and including a number of randomized controlled trials, which is the way in which we really test whether these things really work in the real world. And this is an example from one of our large trials, which is one of the largest done in autism, in fact. And what I show you here is that what we're aiming for the parent is to become what we call more synchronous. And won't go into how we define that, but essentially you can imagine what it is. It's like they're more aware of the child's communication and respond in a way that meshes with the child and also leads to the child to do more. So there's a definition of synchrony. The red line here is what happens to the group of parents who are in the therapy, and the blue line is treatment as usual. And the difference between those lines represents what we call the treatment effect. And this is a big treatment effect. In other words, that parents can learn through this technique quite quickly and reliably to develop their awareness and responsiveness in a synchronous way. We've done this with parents across culture, social class, education, ethnicity, and there really is no difference as we've been able to discern. Parents of all kinds can respond in this way, and that's a big response. Then the point is that the children themselves respond to that increased awareness and synchrony from the parent with their own reaction, their own spontaneous reaction. So here's an example at the end of the therapy process. Oh, the mother here is really, and this will be familiar to clinicians about how we try and do this, that she's really following his lead and responding to his cues and then expanding on them. So he puts a little thing up to his eyes, the cups, she does it, and then she expands and turns it into a game. So it's classic parenting. The task and the challenge and what the parents have to learn is how to do this with the neurodivergent child. What we show in the trials is that the children in the red line, which is the children who are part of the therapy program, they start to respond differently to the children who aren't. And that's pretty significant difference during therapy. And you'll see the difference is sustained right the way through after. This is the end of therapy here, and then we follow the kids up after 6 years. So somehow this difference has sustained right the way through for 6 years after the end of therapy. And remember, we're not working directly with the child at all. So this is something happening in the dynamic in development, which the child's responding to. And I just alert you to this point here, which is the midpoint, what we call the midpoint of therapy change, because that's relevant for what I'm going to talk about later. So this shows that this kind of work has this cascade effect, if you like, that you change the parents' reactions and that has this effect on the kids. Here is my first ethical reflection for you, for discussion, obviously, later. So what's key about this method of work and what makes it very different to the behavioral paradigm, behavioral learning paradigm of autism, is that we are not actually trying to change the child's behavior. Right? The traditional behavior therapy paradigm is to have a target behavior that you change through various kinds of contingency reinforcement. Most autism programs really are based on that one way or the other. Here we're not trying to change neurodivergent behavior at all. We're setting up a new dynamic within the naturalistic relation in the family. And the child spontaneously, it's very important that what we are measuring in the last slide is the child's spontaneous approach to the parent. Not in response to what the parent does, but a spontaneous approach, what we call an initiation. This is important in my view because this is an expression, I would suggest, of nascent moral agency. Right? This is the child doing something because they wish to, because they decide to, because they are impelled to. And that kind of preserving that kind of moral agency right from the get-go seems to me an important fact of this style of work. It's also, as I said before, well aligned to these well-studied processes of developmental progress, and I've made the distinction from behavior therapy. So this nice paper by Joe Bevertz, who I hope's online, I think he is, and Christian Hens here, who's here, actually talked about how we could try and square this circle between healthcare attention, healthcare involvement, parental empowerment, and preserving a child's moral agency. And I'm just going to suggest that this kind of method, to me, is aligned to that. Then I want to take us a bit further into the kind of detailed science that we've done on this around development and see what it teaches us. So these childhood initiations are the key thing I'm pointing to. We find when we do mediation studies in our trials, and we've done about 7 randomized trials which basically show this, that it is the parent's synchronous response that leads to that. You can do these mediation studies which show a causal relationship. But more salient is that we then look at the child away from the dyad with other people, both what we call generalization across context, so we're out of the dyad into everyday life with other people, usually people that the child doesn't know, like researchers, and over time. And what we find is that these increased child initiations in the dyad generalize to improved child engagement with the researcher when we do the structured ascertainments in the research setting. And those in turn link with a lot of parent reports about family functioning and improvements, etc. What's more than that, when we do the 6-year follow-up, which I mentioned before, so the children by this time are in middle childhood, around 10.5 years, remarkably, and I think it really is remarkable, that when we look at the child's engagement with the researcher 6.5 years down the line from the therapy, they still show that change, and that change is mediated. The change that we see 6 years after treatment is mediated by what happened during therapy. And we can show that through these complex mediation analyses, and this is all published work. Also, 6 years down the line, we do a lot of other measures of parent report of how the child's doing and teacher report of how the child's doing in school. So you imagine this is a 10.5-year-old autistic child who's had the therapy preschool. Teacher obviously doesn't know which child's which, but overall, the teachers of these children report them as more adjusted into the community relationship of the school, as in we measure with the violent. So what I learned from this is the salience of of this kind of social initiation of the kid in the dyad early on, and how salient this is for later development, but also that these are autistic children becoming more social, right? With more social motivations, social initiation within a dyadic context, and also within a context with strangers. And that's the nature of the improved, what we think of as improved social functioning, if you want, or the social engagement of the children following this. They're still autistic, but they're engaged more socially. And the question then is this an outcome that we would all desire? How does it fit with the aims of the neurodiverse community, etc.? And I just want to, I mean, you will make your own mind up on this, but I just want to bring in work that I've done more recently with colleagues, including Joe and Dinah Murray and Damien Milton from the UK, who are all autistic, and myself as neurotypical, on a phenomenological inquiry where we really tried to dig into our own comparative lived experience in living across autism, non-autism. And I'm not going to go into any detail about this. It's published work, as you'll see at the bottom. But I just want to highlight two bits for this small bit of the talk. Firstly, one of the things that we really established was how, and the items here in red are those that we really were very common between us across the divide. Small sample, okay, 4 people, but we're very common across the divide. But what was striking was how important and salient early trust was. We want to be in an environment where we feel trusted, affirmed, loved, valued, and accepted. And that was true. It was completely common in both quantity and quality between us. On the other hand, what we call here social joining, and in green are the things that were really different between us. The experience of early social joining was painfully different when we went back preschool and early school years. So one of the things that we hope to promote through the kind of work I've just described in those early relational terms is a sense of basic foundational trust, an early experience of acceptance and understanding in your early environment with parents. And I think that's consistent with what I've heard from many patients in clinical work, but also in this phenomenological work. So just to finish, I'm just going to talk a little bit about the future. So how might we build on this kind of work? And I want to point here to another finding in our phenomenology, which is that, and this won't be a surprise to most of you, but it came across very strongly, and it's I think, an extremely important finding for us currently in our current conversation, is that one of the things that was really different between us was our early, what we called the sensorium, our early experience of space-time, sensation, and adjustments to that. I want to say it's more than sensory sensitivity. This is very basic experiences of space and time, the flow of time, the integrity of space, etc. And as a shorthand, sensorium, I think, is a good term. And that seems to me foundational, from where I stand at the moment, foundational for what the experience of neurodivergence is, as far as I can understand it, and I hear it from others. What we established, I think, in this work and in the research work that we've done with the therapy is that the social side of the phenotype, if I could put it like that, is a much more malleable and less salient issue. And all autistic people who talk to me agree with that. So we've shown that actually the social part of the phenotype, if you want to put it like that, which was, when I started the work, thought to be primary as a descriptor of autism, is actually a secondary thing, and it depends a lot on your environmental transactions. But the much more primary is these sensorium experiences. So when we come back to our model of how we can work with parents and children early in life, our first go at this, which I've just been describing to you, which was developed like 20 years ago, focused very much on social communication in a way. Although, interestingly, one of the things we found when we actually looked at the findings of the trials is that the children's repetitive stereotype behaviors, so-called, the stimming, the sensory disturbance, actually improved even more than the social communication as a result of the therapy I described to you early on. And, you know, that's an interesting fact. It's, in our terms, cross-domain. But I think it's well understandable why that should be, but we could have a conversation about that. So what we did early on, actually, in scientific terms, actually reduces the amount of stimming. And that's not to say we want stimming to go away, to anticipate some comments. It is to say that stimming, in my view, is often the result of distress and arousal and feeling uncomfortable, and it's a self-soothing behavior. And if you actually feel better in your own skin, you probably don't need to do it so much. That would be my simple explanation for why we see the behavior reduce. It doesn't go away, it just reduces. But the question is, I'll leave you with, is how we could adapt the early model that I described at the beginning to these early sensorium differences that we're learning about much more, both from listening to autistic people, but also from the early neuroscience, which is focusing on this very much as well as convergent. So this is not just about the interpersonal environment, it's also about the physical temporal environment around the child and how we could work with that in addition. And just to say, the salience of the phenomenological inquiry that we did, but plus all the other work that's happening within the neurodiversity conversation, plus our developmental science, which is really, as I said, convergent with that. Both those things, I think, will inform what we do here. So this is how I see the intervention, as it were, that kind of approach to intervention moving forward. But I leave that to you for our discussion, and also to the sweet boy that I met, and hoping that he would be more comfortable in his skin. He'd still be autistic, but he'd be more comfortable in his skin if he'd had what I've described earlier in his life. Thank you very much.
Jonathan, do you stay here and you?
Yeah, okay.
I suggest that we turn the sequence now, and that we first look at a few questions that came online. And there were quite a few that I tried to synthesize to what if the parents themselves are neurodivergent? How does that fit into PACT? Yep. And associated to that question is what is the assumption about proper communication in your model?
Yeah, thank you. Yeah, both good questions. So of course, we have a lot of experience working with neurodiverse parents because autism is a familial condition, and it's absolutely the case. This kind of work, what we basically do is adjust it to neurodivergent learning styles. We're basically aiming to do the same kind of thing, So in that sense, it's like based on that fundamental model, but we adjust the way we do the video feedback and working through the therapy to them. And how does that work? It works fine. It is a little bit, sometimes a bit more difficult for the neurodivergent parents to do this, but not measurably so. So for instance, when we do the trials, we have a thing where we look at what are the moderators of the treatment effect, which is, are there things at the baseline, the beginning, that mean that the therapy doesn't work, like ethnicity or social class or the fact that you're neurodivergent as a parent. And that doesn't come up. So statistically speaking, it's not an effect that actually affects the overall effect of the therapy. But you know, in individual cases, yeah, you have to, as a therapist, you have to work to engage the, sometimes it's fine. Yeah, what does it say about, and the other question is, well, what does it say, what is this thing we're trying to get at in the communication? And that's the key point, really. So what I said at the beginning was that what the theory aims to do, what's sort of based is this idea of attunement. Now, that's kind of a formal thing. In other words, it's like, how do you define that? And that would take me too far into how we code these things, which is relevant, but I don't have time really to go into. But essentially, this is about a kind of harmonious to and fro. And it doesn't talk about what you have to say. It's more about the flow of the dialogue, the transaction, attunement. And it's about a kind of sharing. So when we look at the dyadic coding that we do, which we do from videotape, what you see oftentimes with neurodiverse children is the parents are holding the floor the whole time. If I had long, I could go into lots of video examples of this. But what tends to happen is because parents are often totally perplexed by their neurodiverse child, they just don't know what to make of them. Not always, but you know, this is often the case. They will try and do strategies to manage the uncertainty. And often what that is trying to direct what happens in the communication. So you'll see this kind of directive strategy that parents do. And we show that empirically when you look at a lot of these videos. That tends to be what happens compared to parents of neurotypical kids overall. And what we aim to do is to redress the balance in a way. So it's basically for the parent, it's often about just step back a bit, just wait a minute, just watch, wait, look, listen, hear, pay attention to the child's communication. Look, see there what they were just moving. What do you think that was about? You know, maybe they were saying something to you there. They weren't saying it verbally, but they were indicating non-verbally. And it's alerting the parents to these communications, which can be quite subtle in neurodiversity, and helping them just wait and watch until they see those and then respond. And inevitably what happens is you balance up the communication. So that's where the child's spontaneous initiation communication comes from, because they've got space for it. So that's what I'm talking about. There's no prescriptive thing about how parents should be, apart from just pay attention and be aware and learn about their child's communication and intention. And that's the key of it. So it's very individual, but that's what the video feedback does, is to help build, the parent learns that through the video feedback.
Okay, thank you. Time for a quick question from the audience here. Elena.
Sorry, Jonathan, I wanted to ask you maybe just to expand just slightly, and I wonder whether it's helpful to think about how you've adapted this to different cultural contexts. Because, you know, when I showed images like this to mothers of kids with ADHD, they immediately said, oh, I feel so much pressure to be that mother, because it's loving, it's face-to-face, it's interactive, it's the perfect mother. But we also know that lots of cultures, there isn't that much face-to-face contact. Women who have their babies on their back for most of their development because they're working in the fields, for example, and there's no less love or communicate. I mean, you know, so I just wonder whether it's useful to think about adapting this to those kinds of contexts.
Yeah, thank you. I mean, there is, of course, a critique of this kind of work, that it's very culture bound, particularly to sort of white middle class America, which is where a lot of this work was done. And how much of this is a more universal process? That's a really interesting question. So, I mean, for about 15 years now, I've worked in South Asia using this kind of model. When it was adapting the pact to South Asia, and when we started to do that, there were a lot of people who said, "You won't work," because parenting is so different in South Asia. There's not much play, so much. There are all sorts of stereotypes, which partly, like a lot of stereotypes, have some truth in them, but they're like... a lot of people say you won't be able to do it. Well, we did do a cultural adaptation, but it was a very actually systematic cultural adaptation, but it didn't adapt the core process that we were after. And all I can say is that when we study in this way in India and Pakistan, which we've done in those communities, we get the same result. And it encourages me to think that there are aspects of this which are culturally fairly universal. Yes, the en face contact and everything, you know, can seem quite culture bound, but remember that this is all individualized to the particular parent. Using this, it's an individualized therapy, so inevitably we adjust it to the environment of the child, and yeah. So you know, I think that there is an aspect of this that's culturally universal, and this perfect mother thing, of course, is a bane of everyone's life, and not to mention, you know, maybe fathers will get into this at some point, who knows, if they step up enough. But this really isn't about being perfect. And, you know, the great pediatrician Winnicott talked about, you've just got to be good enough. And it was a very wise comment, because really what we're dealing with here are dynamic systems. They're dynamic systems that have a lot of buffering in them. You do not have to be perfect to make this work. You just have to be good enough, which means just to keep the thing just enough to allow the processes to happen, because it's a dynamic system with a lot of buffering in it. And children themselves have a lot of force for development and engagement. So this is not about perfect parenting. It's about actually good enough parenting in a situation where parents often feel very perplexed, and they just need to make enough of a transition into understanding, and it's also confidence that they gain, so they actually can be the parent they want to be with their neurodivergent child. So, but I do understand, you know, I totally accept all these tropes that we have in the culture, and you fall into all these elephant traps the whole time. All I can say is that as we do this in practice, in real time, in the real world, that doesn't come up so much. It's messy.
Okay, thank you very much, Jonathan, also for this lived experience impact in your model. For the sake of time, we'll have to go to the next speaker. Okay, thank you very much.
Thank you.
All right, so we're arriving at a last and fourth and last speaker. And we're very happy to introduce you to Professor Elina Singh. Elina is a professor of neuroscience and society, and she's also the co-director at the Wellcome Center for Ethics and Humanities at the University of Oxford. And she was trained in developmental psychology, but as she told me, like quite quickly, she already turned to bioethics and philosophy of science. And now her core research interests are on the social and the ethical impacts of new developments in psychiatry and in neuroscience, with a focus on children and adolescents. And already quite a long time ago, she got involved in research that really delved into lived experiences of ADHD people. And I think today she will also share some reflections on promoting lived experienced voices in research and on autism and ADHD. Because also recently there have been some critiques of engaging with lived experiences, both in research as in clinical practice. And I'm much looking forward to your reflections on this. Really glad to have you, and please take the floor.
Thank you very much. Thank you for the invitation. And it's been a real learning experience for me just sitting here and listening to all the dialogue for the last few days. And of course, from the fantastic thesis that we were examining. So I am, as you can tell, I don't focus my work on autism. And although I have continued to do work on autism and alongside other neurodevelopmental issues. So I think I probably will make some mistakes in how I speak, and I ask forgiveness for those. I will also talk about my own experience of doing very intensive work with children who have attention deficit hyperactivity disorder, where there really isn't this sort of robust, really progressive sort of active thinking about what it is to have the disorder. But I think that there are some crossovers. And I'll also talk a little bit about work we've done with autism researchers more recently that builds on the early work that I did with kids with ADHD. And then I do want to reflect a bit on some of this more critical engagement with the notion of voice. And I'll say a little bit about why I think that that is useful and important as well. So this was a long time ago, but you know, one of the reasons that I keep coming back to this study, which was the first study I did really directly out of my PhD. So my PhD was talking to parents of children who were diagnosed with ADHD. And as I was doing that work, people kept asking me, well, what do the kids have to say? And I said, I don't know. I didn't ask the children. And then I applied to 6 different funders to try to get a project going that actually allowed me to speak to children. And they all said no. Well, 5 of them said no. And the reasons were things like, well, you know, you can't talk to kids anyway about these ethical questions. They'll just parent what their parents say. They won't be able to give you reliable data. And these are ADHD kids, so they won't even sit still for you. You know, so there were lots of reasons like that this work was rejected, which I don't think would happen today, I'm pleased to say. But certainly that was my initial experience. But then finally, the Wellcome Trust thankfully decided to fund this project. And I also want to say that, you know, people now call it for shorthand the Voices Study. And I didn't realize that the really groundbreaking thing I was doing at the time was talking to children. You know, I sometimes joke that the thing I'm known for in my academic career is the wild idea that you should ask kids what they think about their diagnosis and treatment experiences. You wouldn't have thought that that was rocket science, but apparently it is. So, you know, that's just how, you know, you can be radical without realizing that you're radical, apparently. But at the time that I was thinking about this work, so this was sort of in the mid 2008 to 2013, really. There was a lot of dialogue in the bioethics literature, which shaded into the policy world in a kind of really impactful way, about the concerns around medicating children, particularly for behavioral disorders. And this was in the American context, and of course those concerns continue to be with us, and for a good reason. There's a huge problem of overdiagnosis and overtreatment and overuse of psychotropic drugs in certain contexts. So I want to acknowledge that. This was never about justifying drug use in children, but it was about saying, well, these are very prominent people in very prominent spaces making claims for which there was no evidence, as far as I could tell. These are philosophical positions, bioethical positions that had been theorized but not empirically grounded. And so my work really was to say, well, okay, well, what's the evidence? And for that, of course, these are not uncomplicated questions to ask of young people. But the idea was, well, there's no children's or adolescent voice in any of this material. So when I went to to look at the literature, there was no body of literature that actually thought it's important to speak to children about this. And so the children really were being effectively silenced about their own experiences of treatment and medication. And so, I should say because as you can see, I'm going to say something about the single author nature of this work at the time. I embarked on a series of papers to demonstrate what children's experiences were. And to do that, I had to get to this question of, how do you do this? What is a rigorous, systematic, let's use those words, methodology to actually get children and young people to engage in questions about ethics, about autonomy, about moral agency, about authenticity? Because the claims were, we're turning these kids into robots. They're not thinking for themselves. They can't take responsibility. They're going to, say it's the fault of their diagnosis, the fault of the drug. And so how do you actually examine that? And of course, the first thing you have to do is to really challenge the question of reliability and validity, and take a whole paradigm that comes to us, largely from research that does things a particular way. I also don't like the sort of standard critique of biomedical approaches, because I think they have their utility and they have their history and they have a logic of their own. So it's not about a critique of that approach, but it's to say it's about the dominance of that approach, and the way that those of us who are trying to push the boundaries here and bring new voices into research have to manage that dominance. We have to understand that that dominance is there, and if we're going to make credible challenges and build credible accounts, we have to do it really in thinking through the methodology. So here you see one of the methods, and I'll talk more about the methodology in a bit, but one of the methods that just spontaneously arose as I was talking to kids. A lot of them couldn't actually, initially talk about the sorts of questions I was asking, but they could draw, and they wanted to express themselves in these different ways. Now, this is non-standardized. But when I asked them, what does it feel like to have your brain? What do you think is going on in your brain? What does it feel like to you when you feel like your ADHD behaviors are under control? These are the kinds of reflections that they came up with, which ended up allowing me actually to systematize, because they came up frequently enough. And then you can build a set of standard prompts that are actually not my prompts, but they are derived from what children bring to the table. So my approach really was to throw the kitchen sink at this problem and to use, what is standardly called a mixed method design, but to sort of try to say, well, I'm going to use some of the methodological tools that are in the literature. So I'm going to use some sentence completion tasks. I'm going to use some standardized pictures, but I'm also going to use these other elements that children, as I said, brought to the table. And then I'm going to use just some standardized measures that are out there, such as the Harder Self-Perception Questionnaire. And I'm going to use some of the standardized tools from the medical literature to be able to say, how do these children look again in a field of kids who are diagnosed with ADHD? And then I did the same with the families. And, we ended up interviewing hundreds of kids in the US and the UK, and it was an enormous task, which I don't recommend to anyone if you're doing largely qualitative work. And we ended up with a lot of data. And then I think the other question we have to ask is, what's kind of a theoretical background? I'm always saying to my students, what are your theoretical anchors? Because if you're doing work that is pushing boundaries and discovering new ways of thinking and building new tools, you need theoretical anchors. And so this model actually is one that I've now continued to use throughout my career, which is, those of you in developmental science will recognize Bronfenbrenner's model. And one thing I will say is it allows you to really think systemically about what's going on with a child. It allows you to think about interactions, not just, that are proximate and distal levels to the child. And then most important for me was actually the push really to have people think about this model as not just exerting influence on the child. So that was very much where the sociological and the critical literature was, but of the child exertion also on the environment. And again, this is something that perhaps those of us in this room would accept as a matter of course, that of course a child exerts influence on this environment. But at the time, certainly in, as I say, the critical literature that I was looking at that saw children sort of being turned into robots, there was no sense of power in the child. There's no sense of agency. So the critical literature itself was denying agency to the child sitting in the midst of all of this. So now I want to return to the kind of single author nature of that body of work. And it's part of the reflection on how far we've come. Because at the time, I felt I had to fight so hard to actually get this work to have any traction, that the last thing I was going to do was to put together a young people's advisory group and try to co-design or co-produce my work. My mentors were really largely people like Jonathan, clinicians who I felt I had to persuade that this work could be impactful in clinical work. And so the work that I did was not co-designed or co-produced, and I didn't interact with kids other than obviously in the interviews. I did go to a lot of ADHD conferences. I met a lot of parents, but most of those parents were asking for treatments. They were not interested in the critical element around ADHD. They were actually very worried about it. They felt it was very stigmatizing to them, and they really just said, please just help us. So again, I think things have changed from there. I mean, there wasn't a sense that their kind of the phenomenology of ADHD was something in which parents could also be empowered to contribute to that conversation. And the other thing I heard a lot was parents say, I want him to be in your study because I've never spoken to him about his diagnosis or his treatment. I just hope that he takes his medication. One thing I am, retrospectively feel was a very good thing is that we ended up, because I would go to conferences and I would talk about this data. And as we've seen today, you put it up in 2 dimensions and you read it out and you say, here's what the kid said, or here's what the parent said. And I would have people come up to me afterwards and say, I don't believe you. I don't believe that the child said this. And so I ended up saying, well, if you don't believe me, perhaps you'll believe the actual voices of the children. And so we ended up creating a series of animated shorts, really, where you can hear the children themselves talking with the interviewer around the major themes that we took from the data. And so this is now 10 years later. It's still on YouTube. It's still got some active dialogue from kids with ADHD underneath it. You know, obviously it's old, so it's thinning out. But I know that it's actually used in clinical settings, particularly in low and middle income countries, to help explain to parents and children what ADHD is like. And there's also, you know, what's it like to be on Ritalin, and another little snippet. So it's a retroactive attempt to work with the community, really, to actually say, you know, does this reflect your experience? And I hope it still stands. So the key findings, just to let you know why people were saying I don't believe you, is that you know, that children could actually report on their experiences of diagnosis and treatment, but they need to be facilitated. You know, you need to actually really think rigorously about how you're doing it, and you need to triangulate what you're doing. So if you're going to ask about, you know, a question about authenticity that is not just the surface level, you know, does Ritalin make you feel more or less like the real you, whatever that means to a 9-year-old, then you really have to be clever about it. You have to be thoughtful. How do children of that developmental age, what's their ability to express notions of particularly violations to authenticity? And the same is true for moral agency. You know, moral agency is defined as, you know, in wherever, depends on where you go, but it's the idea that you have a reasoned account of the right action against a backdrop of a framework of understanding of what the good is. So again, you think about your 9 and 10-year-old boy who's hopping around and can't sort of manage incoming stimuli. So what's the kind of representation of that moral agency capability in a child's world? And the story I heard most from kids who were on the hyperactive end of the spectrum was that you're in the playground, and in the UK particularly, other children like to wind up children with ADHD. So that means that they intentionally go to try to get the kid to lose control because it's fun. And so these kids have that encounter on the playground. There's somebody trying to wind them up, a group of kids, and they can feel themselves getting very hot and bothered. They can feel, they describe feelings like becoming like an exploding volcano, feeling very hot, feeling like their brain is on fire. And the next thing they know is that they're in the headmaster's office and they're in trouble. They can't recollect what happened in between. They don't even know what they did. So it's a lack of intentionality that was hugely morally distressing to them because they didn't know what they did, and they also they knew that they didn't make an intentional decision about action. And that is a violation of moral agency. And what the child will say later is, I might still have gone to beat up that bully because I think that that's the right thing to do. But I want to be able to make that decision. I want to be able to make the decision whether to fight or not to fight, and not to be in the headmaster's office without knowing. So that was a beautiful expression of what it is to feel like you have moral agency in a setting that resonates with a child. And that's where actually being on medication, they said, helped them. So how interesting was that? Not turning them into robots, but actually supporting their expression of developmentally appropriate moral agency. And, you know, people, and so the other finding we have is that kids at a very young age desire moral agency. It's not, you know, this is part of a developmental, you know, moment for them where they're constantly testing, what risks can I take? What do I think is right? What do I think is wrong? That's completely appropriate. So they want to be able to do that intentionally. So, you know, some people thought, oh, she's just a drug pusher. I hope that that's clear that I'm not a drug pusher, but certainly the idea that drugs are either blanketly good or bad was something that I think people were invited to be much more thoughtful about that as a result of this work. So the autism relevant work that now this group led by Mayada Elsebag at McGill is doing is trying to take ADHD voices and build a methodological toolkit for the autism community, and particularly for kids who would not normally be brought into research. And so those are the kids who have more difficulty with communication. Maybe they choose not to communicate, maybe they can't communicate and are on the lower IQ spectrum. So these are published papers, so I'm not going to say a lot about them, except I want to talk about the spirit of the methodological toolkit, which is, I suppose, what I really want to emphasize here today. And there's one paper that just looked at what are the methods available in the literature to actually bring these underrepresented kids into autism research. And that's on the left. And then there's the one on the right, where I'll show you a little bit of what we built. So that's what the method is. And then there's a third paper coming out on what the content actually is that we found. So on the methods paper, the study objectives are actually to develop a method and to really think about how you need to flexibly adapt your methodology to the child in front of you. And again, I mean, thinking about all of my sort of having to deal with the questions of, is this rigorous? Is it valid? Is it reliable? And thinking about where this project got to, which was immediately to say, of course, those standards aren't going to work here. You know, of course, what we need to look at is when you're trying to interview a child who is not verbally as functional as the interviewer, you need to bring different resources to the table. And you also need to give that child multiple chances to be able to express him or herself. So the team did use the ADOS to come up with this NVI, nonverbal intelligence quotient, which I know the ADOS is controversial. So it's acknowledged in the paper that this is one way of establishing a certain kind of characteristic for the data set. But it's not the only way. And the other thing to say is that some children wanted the parents in the room, some didn't. And so one of the things that we looked at was, what difference does it make if the parent is there? Which I think is super important, actually, because in the ADHD study, for example, a lot of those relationships were so conflictual, we asked the parents not to be there. So, you know, even that element of who else is in the room, where is the interview taking place, are really important to think strategically about as you're doing this work. And of course, the focus on making your interview protocol accessible and inclusive means you have to pilot it and you have to engage the community in thinking about how you're going to develop this. And this is the McGill group does this in the context of really beautiful work with autism communities. So again, it's part of a much larger project called the Pathfinder Project. So this interview protocol was piloted and then iterated, and so there was an adolescent in the room and a parent behind the screen who was able to talk about the interaction that they were seeing. There was also a parent survey, so that so one of the things that happened quite often in the interview context was that children would repeat things that weren't necessarily true. So if you said, do you have a brother or a sister? The child would say, sister. And, how do you play with your brother and sister? Sister. But the data from the survey said this child does not have a sister. So, it's thinking through, well, what's going on? What is that child trying to express here? and how can we shift it from sort of, oh, well, this is an unreliable reporter, to something that's more useful to think, well, what is the child trying to express? What's going on here in this expression of sister? And again, they did it much more systematically than my kitchen sink approach, but they did use multiple communication modalities. I wish I knew that phrase when I was doing the ADHD work. I would have used it. So the children could work on their devices, they could text, they could draw, they could use, there were standardized picture cards, etc. And the other thing that was really important is that the videos were also, the interviews were also videotaped. So you could look at body language, which ended up being so informative. And the video sort of body language analysis was then read against the verbal, so that they really came together to inform the expression of the child. And of course, because we were looking at how this method was working, we were looking at barriers and facilitators to engagement, etc. And there was a kind of, there was an iterative, everyone uses grounded theory and overgeneralizes its use. So it wasn't a grounded theory study, but it was this iterative data collection and analysis work. So here's the table. I don't know how well you can read it. Again, it's in the literature. Just looking at what the coding scheme looked like, and there was a lot of discussion about was it meaningful to code. So what did certain kinds of communication acts actually mean from the point of view of the child? And probably one of the most interesting and informative ones was the use of echolalia, which differed depending on whether it was immediate or delayed in terms of the communication act that the child was trying to express. And then also because, we want to work with these children, we want to do much more of this kind of work to bring underrepresented groups into research, you have to think about, well, as a researcher, what do I do to mitigate? And so this was something, again, that there wasn't a prior idea of how you mitigate these problems, but as the team did this work, mitigation strategy emerged and then were reinforced in subsequent interviews. So, that was also important. And the simple thing, again, it's not rocket science. So simple things like letting a child get up and move around. I remember interviewing one kid with ADHD under a desk, because that was the only way in which he would stop. I had to contain him somehow. So he crawled under the desk and said, "Can we do our interview here?" And I said, "Yes, of course we can." But, in most interview protocols, even with children, you sort of need them to sit still, as though that's part of the validity of the interview. But of course, that's not necessarily the way they even not just function best, but can tell you the best, give you the best account of themselves. So the other findings were that open-ended questions, again, for those of you who are clinicians in the room, probably you know this, but open-ended questions asking the WH questions were very difficult for kids with language difficulties. As I said, echolalia was used very frequently, but in different ways, depending on whether immediate or delayed. And interviewer flexibility really, really helps kids stay engaged and supports their communicative capabilities. So now I want to pause, having given you, I hope, a robust account of how important it is to bring children's voices into research. And I want to say that, of course, you can see a career built on that commitment. But I have also started to reflect on what it's partly where do we go from here, but also partly how do we kind of make this enterprise that we're involved in as robust as possible so that it stands the test of time, and that we never again end up in a situation where grants are systematically denied because of the ridiculous idea that you need to talk to kids about their diagnosis and treatment. So there is a kind of, we can say that we've all of us in this room and we've moved from a voiceless and largely considered ignorant child to now a consideration of the expert child. And in a way, I feel like we missed something in between, particularly in the UK, where experts by experience, young people are now put on funding panels, they read your applications, they are invited to very high-level meetings at the UN and elsewhere. And it's happened so quickly. I mean, I woke up one day and I thought, how did this happen? I was just arguing for the inclusion of kids. But as you can see, even here, the Wellcome Trust sort of committing to use experts by experience in research. And so while I think that's very good, I feel like we need to go back and really think about what we missed in the pendulum swing. And partly what I think we've missed, and I'm working here thinking with both philosophers in science and also sociologists of childhood who have raised some similar problems here, is that we haven't kind of really thought about the problematics of subjectivity, representation, and expression. So Judith Butler here, writing not at all in this context, but I find her really useful to think with. When I tell the truth about myself, I consult not only myself, but the way in which that self is produced and producible, the position from which the demand to tell the truth proceeds, the effect that telling the truth will have in consequence, as well as the price that must be paid. So this idea that anointing young people experts by experience is actually potentially burdensome, and that it comes with responsibilities, it comes with demands for accountability that we really, I don't think, have a framework for thinking about yet. So questions such as who invites a young person to speak? What are the power actors who are inviting young children to the table now? Well, adolescents, let's say. And I don't speak about adults because I don't do research directly with adults, but I think these questions also pertain to adults. So what is this ground of subjectivity on which we are asking experts by experience to not just deliver their expertise, but develop their expertise? And who among them is invited to speak and who among them is not invited to speak, and who do they speak for when they speak? And who wants the mantle of expertise? Is that a mantle that even fits, or is it our scholarly, academic, elitist, ivory tower rhetoric that is being a part of the invitation to people who are not in our group is join us, be experts. But perhaps that's not the right framework at all for what experts by experience bring into the research community. So going further into the sort of philosophy of science world, Theodore Adorno talks about how do you tell stories about yourself, and what in relation to your narrative of what's happening with you, how does that relate to broader social relations? And I think this is something that the thesis really picks up very nicely, because this is about speaking being a political act and knowing what the political environment is in which you speak and are allowed to speak. And also, of course, does it mean that it's all okay now? Does it mean that since we are inviting experts by experience to join us, all that past history of violence and subjugation goes away? And or if not, then what do we do with that history? And then I do think the price paid for speaking, particularly for young people, is something I want to think with young people about, because I don't think they're aware of the ethical ground that has been opened up for them. And I don't think that they're necessarily aware about the socio-political dimensions of speaking, not as individuals. If they are part of communities, and this is again where communities are so important in holding kids and providing a ground, and we've seen that with some work we've done with mental health advocates in African settings, where there's a burgeoning ground that holds them politically, but it's still very dangerous for them in some contexts, stigmatizing and more, to talk about their experiences of mental health challenges, particularly if they shade into experiences of, being LGBTQ+, for example, non-binary, etc. So there is a real danger here that I think is important to think through. And of course, we don't want to normalize all this, because the whole point is we don't want norms. We want radical edges all the time. So how do we keep those radical edges and avoid commodifying voice? So I also want to say that these questions that I'll go on with, I have no answers, as I said in my introduction. I don't have any answers, but I want all of us to start thinking about these areas. And particularly about epistemic humility, because I think that limit of knowledge is also an important question. So why am I so worried about this? In part because there was a pendulum swing. And what do we know about pendulum swings? They go backwards. So the promise of many voices is that we will continue to maintain our radical edges. The danger is that people will say, oh, it's just opinion. And opinion's gone out of fashion. This expert by experience, this voice stuff, it has no normative content. It's just opinion. And I see, shades of that already happening in spaces where people just don't really want to go there and listen. So I think that's why it's so important to make what we're doing robust and accountable, both, as I said, for the safety of the people we work with, and who we invite in, but also so that it's more not on our terms, but on other terms, and so that we can build an ethical framework that really thinks robustly about knowledge and the limits of knowledge and accountability and responsibility. And I think that's part of the respect we owe to members of neurodivergent communities who dare to join us in research, really. So, I've thought about this a little bit theoretically, and I won't talk too much about this, but I think that there's also ways to think about voice layering, just like there is about vulnerability layers. Because, of course, as we gather into communities, we aren't really just talking about individuals anymore. We're talking about gatherings, collectivities, multiplicities, layers, and intersectionality, I think, is a really good framework to think with through this. So I go back to Bronfenbrenner, constantly trying to update Bronfenbrenner, and ask, well, in this ecological system, what voices remain unacknowledged and uninvited, and what is the price paid for speaking and representing? Thank you.
Thank you, Alina. It was really a wonderful presentation. I much enjoyed it, especially in the end, also the critical remarks. I've been looking a bit at the questions online, and I've seen mostly remarks, actually. Also much recognition and appreciation for the humility that you and also other speakers brought to engage with neurodivergent communities. Also some questions in the beginning on how the things you presented at first would relate to people with a cognitive disability, and I think this question got addressed really well, or at least you gave some suggestions. So I think for now we can maybe take maybe just one question from the audience, because we're also running a bit out of time. And I see a hand going up here, and it's someone who didn't speak yet, so I'm glad to give you the microphone.
Thank you very much, Elina, for your great talk. I have a question about the final part about the swings and the dangers and the dreams of including experiential voices. If I'm included in consortia who do all kind of mental health research, and they all, almost by default, the new norm includes participation, co-creation, and make use of experiential experts. You talked about the danger of who's invited and how are people invited. Do you also see a danger of participation washing, of using it as a label? We do have it, but we don't care about the quality about we include them as long as we have some participation. Well, sometimes that's a little bit of the impression that I do get. I don't know whether participation washing is a term. I just make it up by now. But well, is that also because you described a different kind of danger? Do you have an opinion about that?
Yeah, and thank you for the question. I mean, I think there is a lot of that. I mean, we call it sort of tick box exercise, right? Where you say, oh, well, we spoke to a group and they said it was fine. But research is a process, and there is an argument for perhaps there are different stages of the life cycle of a research project where you need more and less participatory input. But I think that should be part of a strategy. So I do think that the work in co-design and co-production is usefully trying to work through these things so that it's not as though you get a tick box from, you know, some entity at your university, which I do now. It says, have you consulted the community you're working with about your research? It doesn't really talk about how to do that in a valuable, productive, respectful way. So I think it will get better, but I absolutely think there's a lot of, I like this, what is it, participant washing. I think there is a lot of that. And I think that's because some people are genuinely just reluctant and don't think it's useful. So I think we also need to, rather than saying, well, gosh, how ridiculous that is, we need to understand it in order to be able to effectively counter it.
All right, thank you.
Thank you.
I think we're arriving at the end of this symposium, and just for some final words of closure, I thank you, Elina. I will pass on the word to Ilse again.
Okay, thank you all for being here, and thank you to the speakers, especially the guests from abroad. I've definitely enjoyed this symposium very much. I hope the same is true for you. I think we were given lots of food for thought, no clear-cut answers, but as you indicated from the beginning, I think you were looking for insight and inspiration, and I'm quite confident that that is exactly what this morning has given to us. We will follow up by email. There were lots of things that we have touched upon, discussed, papers that were referred to. So we will definitely get back to you with an email with further reading and suggestions. Thank you all for being here, and let's keep in touch in case you're interested in continuing this debate. Thank you very much.